It's one thing weighing a boy or girl, calculating a BMI, coding and submitting the BMI to the payer, all that stuff is easy peasy. What you do with the conversations and connecting with families to see if they're interested in working on change, that's not easy work. And that's the focus of our keynote presentation with Molly Basch and Sarah Hornack. Hey folks, come on up or come on down. So Molly and Sarah will be taking us to around 1:30. At 1:30, we'll have another break so that folks can stretch and we can clear the tables and get other things and we'll start up our afternoon session at 1:45. So any other big questions before we get launched in the How to Motivate Change? Actually, we need to do motivational interviewing for pediatricians to start doing the change. Are you ready? Are you ready to make change? Everyone raise their hand if they're ready to make change. Okay, we solved that part. Okay. Oh, I have one last thing. If you didn't pick up one of these little key fobs and Apple tags, they're pulling the, they're identifying the winners and actually giving real Apple tags to the winners by 1:30. So at the break is your last chance to get in line for that. And then please consider sticking around for our reception and dinner. It's a great way to connect and learn from each other. Molly, Sarah, take it.
Thank you, Dr. Weissman. It's really had a little bit of a Price is Right moment there. That was exciting. We're really pleased to be with you here today to talk a little bit about motivational interviewing and how you might sort of use some of those strategies in your practice. I'm sure most of you already are, so we'll just try to expand and maybe cover some concepts that you haven't thought about in a while. All right. Nope. Okay, this way. We don't have any conflicts of interest to report. So we're going to dive right in to give an overview or a definition of motivational interviewing. Again, the AAP guidelines that we're all talking about today did give a sort of glimpse of what this practice is like, both in the evaluations and assessment section, but also as an intervention tool. So we'll talk about what that definition is. We'll highlight some of the brief research evidence to sort of show why this might be useful to implement within a pediatric care practice, and then discuss some key facets of the approach, get a little bit more specific, and then present a brief model of MI. Thing's a little bit sensitive. So according to Miller and Hornack, who developed MI in the 80s for use with individuals with substance use disorder, this practice is a collaborative conversation style for strengthening a person's own motivation and commitment to change. So to sort of restate that, it's really a very gentle and respectful method of communicating with others about their difficulties with change, but then also thinking about the possibilities for engaging in different or healthier behaviors. This isn't meant to be necessarily like a list of techniques that you're going to be using with families. More so it was developed as really a style of engaging with others. And that's really what leads us to this spirit of MI, which is really thought to be the foundation, in which you're working with families and with patients to really enforce autonomy and to give them agency to be thinking about the changes that they want to move forward with. And also really working in this collaborative way. Molly and I are tackling this presentation together to sort of model collaboration is good. It is also very much this focus on the collaborative nature versus a more prescriptive or directive approach. The metaphor that's often used for this is this idea of a child on the playground. The parent is there helping them, guiding them, ensuring safety, but also really allowing for that individual exploration and problem solving. And then finally, the last piece of that spirit of MI is the evocation piece. So as providers, we really want to elicit our patients' ideas for change, talk to them about what their concerns are around that, and really focus in on why they may be making change out of personal interest versus some external rewards. Okay, so we know from previous research that MI can be implemented successfully within the context of a pediatric office. So Resnicow et al., for instance, found that brief MI offered by pediatricians led to clinically meaningful reductions in BMI. And this was done within 4 physician visits and 6 dietitian visits over the course of 2 years. So you can see that even with sort of there's a sort of lower threshold there for dose response or intensity than maybe some of the things that you all have already heard about today, like IHBLT, for instance. There can be changes with sort of that lower intensity. Another trial found that pediatricians who acquired MI skills then saw associated increased exercise, weight loss, and reduced screen time in patients. And then finally, there was a nationwide survey of about 700 pediatricians that indicated that the majority of you desire training, and that those who had recent training in motivational interviewing were reporting increased self-efficacy around delivering some of those skills and principles, and that we're perceiving that it was more effective. I would also note that there has been some research that families and patients that are participating in motivational interviewing focused approaches tend to have better adherence to some of the sort of goals that are developed through that than control groups or those that aren't receiving MI.
Vertically challenged here, so let's get this set. So now that we've learned a little bit about the background of MI, we're going to focus on some of the main principles of it. The first one being a really, really important one, which is expressing empathy. And it's so important that we're going to introduce it now, but we'll actually come back to it a little bit later on to dive a little bit deeper on empathy. But empathy was traditionally thought as a very, very key component to any effective psychotherapy. But we now know that it's also really important as a component to building motivation for behavior change. So in healthcare, empathy refers to the clinician's really sincere desire to understand the patient's or the parents, the family's experience and their motivations as they relate to the problem at hand or to the topic of discussion. So in other words, really understanding where that person is coming from, feeling some sort of what they're feeling within themselves, and then expressing that understanding to that person. So those are really some of the key components of empathy, the use of empathy in healthcare. It requires some other key things, which are 1, listening, 2, sort of asking questions, and then 3, reflecting what you hear. And doing those things in particular ways, doing them in a careful way, a curious way, and a non-judgmental way. So that's sort of all infused within this principle of empathy. And so like I said, we'll come back to it in just a bit, but a little primer for you all. And then jumping into the second key principle, which is developing discrepancy. And this is really built on the knowledge that we know people are more likely to change when they can see that their actions aren't in line with their goals or their values, that there's some, discrepancy there that exists. And so you might wonder, like, well, how do we know what their goals and values are? We can't really assume those things, so we have to ask. You might say, what are your health goals? Or what do you want your child's health to look like as they age or as they grow? Why would you want to make some sort of change? Those are some good kind of questions to get at what their goals and values may be. And then again, really listening and asking follow-ups to make sure you're understanding where they're coming from. The answers that are provided really build the foundation for identifying those sources of discrepancy between what, patients or parents may be saying and what they're actually doing. So you may be able to gently reflect some of those discrepancies by saying something like, it's clearly very important to you that your child reduces their risk for diabetes, and it's really hard to prioritize these protective health behaviors, whatever they may be. So just as an example there. The third principle, so there's 4 principles that we'll cover. The third one is rolling with resistance. This is a fun one, fun and challenging, but feels good when you accomplish it. So we know that change and resistance often go hand in hand. And I will absolutely be the first to say that this is, a personal experience for me as well, right? Changing is hard. And people resist change for many different reasons. It can be really difficult to navigate these situations, and really difficult for healthcare providers who, happen to have a lot of knowledge about health and then also just really want to help. So you can be put in this particularly challenging position of figuring out, how do I help? So one of the first, most important things to do is just accept that resistance is going to be there. Really just accepting it, that this is natural, it's expected, it happens for all people, even for ourselves. And secondly, knowing that there are ways to avoid increasing it, right? To not make it worse. One of those main ways is we don't want to try to convince people, right? We don't want to try to, try to convince them that the path they're on or what they're doing is wrong. That's, in healthcare, can be termed something called the righting reflex. That can be a reflex we experience. But in fact, humans have their own reflex, which is when someone's trying to convince me to do something or persuade me, I don't really like that. I sort of resist that. So we actually want to take a different approach. And the alternative is really rolling with, or working with, or rolling with resistance in those moments when you notice it, when you feel it in the room. And that can involve a lot of things, but some of it is, maybe we drop the approach that we're working with. Maybe we come back to just those really important listening and kind of questioning, asking skills to understand better. Maybe we, just emphasize, hey, any baby steps, any sort of change is great here. And we also emphasize that this is their personal choice, right? We're here to just, be a partner to collaborate, but they're the ones that are making the decision. Oh, and I jumped ahead. Sorry about that. I got so excited about rolling with resistance that I just rolled right past the 4th principle. Thank you. So our 4th principle, last but not least, is supporting self-efficacy. So this actually is really important. We know that health providers y'all are experts on many things, right? But in the spirit of MI, patients, parents, families, they're the experts on themselves, right? And so MI is all about recognizing that. It's also all about empowering individuals to take a strong stance in their own treatment, to partner with them rather than just prescribe things. It's built on this assumption that people can grow, that they can change, that they have those skills within them to do that. So it's really important for providers to sort of strive to have that, hold that attitude, that who I'm working with, they can change, they can grow. And, within that, recognizing individual strengths, recognizing any efforts towards change, praising those things is very important. And especially in the case of, working on weight, health management, where parents and patients may be particularly primed to feelings of like failure or rejection. We want to be extra sensitive to that. So now we have a word cloud here. We'd like to take a second to have you all just reflect on a question, and then we can kind of see what this brings out for everyone. But the question is, what feelings does pediatric obesity treatment in primary care bring out for you? And so we've got I think if we advance, we've heard you all have had some practice on this today. So hopefully this goes smoothly. But any words, phrases, what this brings out for you? No right or wrong here. I got so overwhelmed by the response. I did see a lot of like stress, overwhelm, frustration.
Utility, frustration.
Frustration is a big one. Gosh, yes. Oof, it's overwhelming just to look at this. I'm feeling it.
Our empathy is getting activated, for sure.
Yeah, wow, we're seeing I'm seeing stress, frustration, challenging, complexity, sadness, concern, unsupported, oh my goodness, hopeless, some motivation in there, some learning, gosh, and you all are just like keeping it coming. Love this. I feel like we could just keep doing this. The whole rest of, that's it, we're done. No, but yeah.
But yes, I mean, clearly a lot of frustration is sort of stayed at the forefront there. And I think so. I think this is where this is headed. And actually, you set us up because we are moving into sort of where we go for therapy, which is Brené Brown. And so we're going to focus a little bit on empathy in particular, because I think in thinking about the responses that you may give to that word cloud, we also sort of were thinking of the question, what is it that our patients feel? And I bet that, and in our experience in working with this population, there's often so much overlap there and sort of the frustration we feel and what our families are experiencing as well. But we'll let Brené take it away for a minute.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, Not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay. Oh, now I'm gonna, okay. But anyways, yeah, feel free to, you can just Google Brene Brown empathy. Sometimes I go back to that just as a reminder of what's this real foundational skill about? And it is a skill. So we know that y'all have empathy, right? Y'all are probably more empathic than the average person out there. But empathy is a skill that can be built upon. So it's not like we just reach a level and then, okay, we're at our max. And it also can be built upon to be used more in certain situations, or kind of to hone in on in certain situations. For instance, like working with families around obesity care.
Yeah, I think that's a really important point, Molly, particularly because we know that it is a sensitive topic for providers to bring up, for families to talk about. And so, there has been a lot of evidence that can show if we come at the situation with a really empathic stance and trying to understand and meet patients where they are, it can really help combat some of the social desirability in the responses that we might get. But also, there's been some research evidence to show, like, coded sessions with pediatricians, if they're using empathic language, then that is connected to greater what we call change talk in motivational interviewing from our patients. When they might say, I desire to make a change, I can make a change. This is why this is the reason I want to make a change. So we're going to dive into now a practical MI tool that was designed actually for implementation in primary care by the Family Lifestyle Program here at Children's a while ago by some of the folks actually that you heard from already today, including Kofi Essel and Alicia Tucker. And so we're going to try to do it justice, but I see Alicia over there if you want to shout out if we're missing anything, let us know. You can see by the title that this particular script that you all were given, I think it was on your table, was really designed to facilitate a conversation around promoting healthy nutrition. But I would say that clearly when we're talking about, I saw complex come up in the word cloud, there's no bounds to the complexity within the management of obesity. And so you could easily sort of interchange here dietary habits or eating habits with improved sleep hygiene or increased physical activity or eating meals together as a family, changing the context in which meal times happen. So, I think there's a lot of possibilities about the ways to tweak this. So at the outset, in typical MI style, you really want to open the visit by explaining the purpose of the visit, your ideas about why you may be coming together. And with that opening statement, really convey the idea that you're here as a guide and not necessarily to kind of lay down your expert opinion or direct the conversation. Set that expectation. And then one thing that you will notice kind of throughout the script is sort of, asking permission to provide information throughout. So you may say something like, how does that sound? Do I have it right? Do you have thoughts about other topics that you'd like to cover today? And in sort of thinking about having these conversations with family, we also want to be really sensitive to our word choice and our use of language. So of course, certainly thinking about the use of person first language. So, we want to say a teen with obesity rather than an obese adolescent, for instance. And then you also would probably noted in the guidelines that there are some weight-related language tips, and families have been asked to share what are their least and most preferred terms when speaking about weight. So those least preferred terms being fat, morbidly or extremely obese, large, chubby, whereas more preferred terms that come out are weight, unhealthy weight, high BMI, or plus size for girls sometimes. Along with that, though, I would say that it's also really important to be sensitive to individual differences. And it is okay to ask families, what words would you feel most comfortable with as we talk about you or your child's weight today? And I think, where you can, also trying to pick up on what words the family are using more generally and mirroring that in your conversation.
So, in that, the sort of opening, when identifying whatever broader health topic you're going to start talking about, here in the script, we're talking about a current eating behavior. You want to get a good idea with where the individual or where the parent feels they're at with this. So you can start with a broad question like here, and then follow up with more specific ones, like, what does your child's breakfast look like? Or how many meals per day is your child typically having? What types of drinks are they typically having? So kind of probing to get some more specifics. Again, in sort of that open, curious, kind of gentle way, to understand where the family is at a little bit better. And then, a really important part is that the provider should take a moment to consider, to have the parent or the patient consider what do they feel is going really well? What are they doing well in this domain of eating behavior? And then what areas might be going less well? What are some areas they feel like they could use help with, or that could be targets of kind of improvement? After doing this, you may feel the urge to jump straight into, we've identified areas of improvement, let's set some goals. But there's some really important kind of intermediary steps that we don't want to skip. The first one being assessing readiness to change. This is a really important next step that helps add context to to this whole kind of encounter and this relationship these goals that you're embarking on. And this tool of using sort of a readiness ruler of sorts in and of itself can be a motivation inducing tool, just to have conversations around that. How many times are we asked, to rate ourselves or where we're at with something, and really think about that. So you can use it as a way to rate how ready do you feel to kind of make changes in this area that we've just talked about. You can also substitute readiness for importance and confidence, because those can be other kind of helpful key contextual questions. Sometimes they're aligned across the board. If they're aligned highly across the board, that's great. But if you see, they feel really ready, but the importance of this behavior isn't very high, that discrepancy could tell you, maybe we need to choose something else, because we might not have a whole lot of traction here. And then from there, the provider can summarize and sort of reflect what they've heard, emphasizing the areas of improvement as some potential targets for their providing some counseling. And so in the spirit of MI, before providing any counseling, you want to ask, can their permission to give that counsel, to say, I happen to know something about portion sizes, about recommendations around some of these areas. Would it be okay if I, gave you some information about that? And you could think about how that sounds for yourself or your family. We don't have the nutritional counseling sheet that they talk about in the tool today, but a good option for a substitute could be using like recommendations from My Plate, for instance, of using that as a way to kind of guide some of the counsel or guide some of the educational content. Next, you can focus on sort of inviting that individual to maybe select a particular domain of interest within the category, which for this was eating behavior. So could say, for instance, like sugared sweetened beverages, that's a domain of interest, something that I kind of feel like I want to work on and I'm ready to work on. And then we can start the goal setting process. Again, starting with asking permission to help them set some goals, to guide them in that process. We want to use a SMART goal framework here to really optimize success in meeting goals. And then, ending the ending portion of the encounter could be in, sort of summarizing what those goals are, what was set, ending with some encouraging statements, some, instilling confidence, praising where you can, keeping it a really sort of positive encounter, because this is hopefully not going to be the last. And so we'd like them to, feel good about it and to return and keep feeling good about it as they can. As well as, again, kind of setting a plan for follow-up. So we just, heard in the beginning that even, just a fewer amount, every other month sessions or visits like this can have a significant impact. But that might need to be changed or modified depending on the patient or the family. And so would leave that up to you all to decide if frequency would need to be increased.
And I'm actually going to pop back to this a little bit, Molly, if that's okay. I do think that the rulers can be really valuable, but I don't want to miss kind of the probing questions there, because I will say I'm often really surprised when I utilize this tool that even if like the straight question, for instance, if a patient says, I'm somewhat ready, I would put myself at a 3. And I say, well, why did you choose a 3 rather than a 0? Even with that interval, they will come up with some of their like sort of personal reasons that can get at that intrinsic motivation and can help guide you in terms of going forward. And additionally, I would say when we're sharing information within MI, so kind of when you're negotiating the agenda and sharing those sort of pieces of expert knowledge that you may have, that you do have, There's an approach called elicit, provide, elicit within MI. So you want to ask the question, could I share some information with you about sugar? Then you can let them know, 4 grams of sugar equals 1 tablespoon. And they're all like, what? And then you're like, what did you think about that? So then you elicit again, like, what is their response? And I think when you kind of get at some of that surprise, it can also be really generating some of that change talk. And then finally, Molly alluded to this a bit previously, but sometimes folks really aren't in a place or coming to us in a place in which they are ready for change. So it's okay to suggest making a very, very minute change at that point, or even sending them away with the sort of plan to think about making a change and identifying where they might think about making that change. Or saying, let's come back and reconvene and talk about this again. So thank you all very much. We're happy to take any questions with the few minutes that we have left. I would also say we've kind of collated along the way like quite a list of resources around this topic, so feel free to email either of us if you have interest in that. Yes.
Kristen Johnston, a CPMP in Gaithersburg. Does this nutritional counseling sheet exist, or?
It exists. We can certainly ask for it. I'm sure the dietitian that worked on this project, Laura Fisher, was crucial in sort of building that. So maybe there's a way that we can share it with Abby to get shared with a QR code.
I will interject a little bit. Some of these are living currently on the Children's National SharePoint, but we are planning to share them with the PHN website as well. So they should be accessible to everyone shortly. But if you're within Children's, they're on the Goldberg SharePoint.
Thanks, Alicia. All right.
Thank you all.
Thank you, Sarah and Molly. The hard work's having a conversation with our families, but that's where we all need to start. So I appreciate you providing some perspective and guidance about really how to start those conversations.